So in the last segment, we talked a bit about the Trump plan to reopen the American economy. And not just the economy, but America altogether in terms of the society, in terms of the social relationships, family connections, somewhat gathering together over time with phases 1, 2, and 3. Let's go ahead again and hear in cut 2 Dr. Deborah Birx talking about the first phase, and we will introduce our medical guest.
Phase 1. Again, you have to go through those gating criteria related to 14 days of decreasing evidence of illness and decreasing testing despite adequate testing. So phase 1 begins with all vulnerable individuals, including those with comorbidities, continuing to shelter in place and ensuring that those that first go out into the public are not those that are most vulnerable to bad outcomes in this disease. And then ensuring that we continue to do 6 feet maximum physical distancing in public spaces, continuing to avoid large gatherings and all non-essential travel. For the employers, next slide. Again, if a vulnerable population needs to return to work and cannot be teleworking, there should be special accommodations for all vulnerable populations, as well as options for teleworking. We believe every employee should encourage work return in phases from 20% or 25% to 40% to 50%. And again, minimize all non-essential travel. Phase 1 continued. Next slide. If the schools are already closed, they should remain closed. All visits to senior living facilities and hospitals should continue to be prohibited. Large venues, including sit-down dining, can only be operated under strict physical distancing protocols and maintaining those 6 feet. Gyms could open if they, again, could adhere to strict physical distancing, and elective surgeries can resume on an outpatient basis.
Again, that's Dr. Deborah Birx at the White House press conference yesterday explaining phase 1 to the 3-phase plan to reopen America from the Trump administration. Let's talk about this, particularly from the medical perspective, with Dr. Dennis Deruelle, MD and FHM. He is a physician and practicing hospitalist and author of Your Healthcare Playbook, Winning the Game of Modern Medicine. Dr. Deruelle, welcome to Jimmy at the Crossroads. It's so great to have you on this Friday.
Sure.
Thanks for taking the time. Really appreciate it. So, fundamentally, how do you see things as being at right now in terms of the coronavirus crisis and how it's being handled? And are we ready for a 3-phase rollout of America in this grand reopening of sorts?
Well, I think that we were slow on the uptake. I do consulting for a company called Cepheid that was developing a test for this. They interviewed me on February 11th. They asked if they should go on and develop a COVID test. I said, of course, yes. But if you think about that, that was February 11th. So I think that our testing was behind, and I think that our distancing was probably behind. But today, I think we've caught up to that. So if I was judging now, I'd say we're now at a B. We were probably at a C- when we started this thing.
So then, ready if it's rolled out in a slow 3-phase fashion like the administration is proposing to states?
Yeah, I think that the key thing is that there's a gating criteria. So, the phases are one thing, but until a state has certain things in place, first of all, they have to track influenza-like illnesses, which are really COVID illnesses, so they're the same. And you have to be able to track those, and they have to be going down. And we could get into the esoterics of trajectory, but it has to be over 14 days. And then the number of tests, the cases, have to be going down as well, but that's dependent on how much you're testing. And then finally, hospitals have to be ready. And they're kind of vague on that. So I think that if you evaluate different states, some states are probably close to that today. Others are not, and that's going to be the real driver because you got to pass that gate to get into the phases. One thing I would say is that doing elective surgeries is something we shouldn't have stopped in some places. Imagine this same plan about a month ago where we said, hey, if you have enough hospital beds, if you have enough protective equipment, and the prevalence in your community of COVID is low, let's go ahead and continue some of these elective surgeries. We're closing hospitals now because they've lost 50, 70% of their revenue based on these surgeries. So that's something I'm really happy that they're liberalizing in this.
Now, the question, of course, is when states will start actually following this. Will it be the end of the month, April 30th, which is the administration's target date, or could it be later? Is it going to be state by state determined? I mean, clearly that's going to be the case because every state has the onus on them to make that determination, as should be the case. But how widespread do you think it will be for states to be able to take that phase one first step?
Well, I think something is really important is antibody testing. You know, I saw the first antibody data. I just retweeted it out of Santa Clara, California. And you should look at that. And what they found was the prevalence was up to 4% of the population, which would have meant 81,000 cases, which is about 85 times greater than the cases they have today. So what does that mean? It's what we've known. There is more of this than we know. There's more immunity than we know. And so I think an important thing is understanding which states have that prevalence that's higher, which states have the testing capacity. So antibodies and PCR, or testing for the virus, both have to be in place. And I think once you test the water with that, we're going to learn a lot more. You know, in Boston, 30% of the homeless population they tested was positive and asymptomatic. So I think if you look at the Iceland data, they tested 10% of the entire country, and half of the patients that had it were asymptomatic. So that's something that we're going to find.
Dr. Dennis Deruelle, our guest here on Jimmy at the Crossroads. So one of the things that's really helped doctors to be able to carry out their practices in the midst of this crisis has been the use of telemedicine. I mean, it's been incredible to see technology making it possible for doctors to treat patients at home. And we want people to be at home as much as possible during this pandemic, to be sure. So let me ask you where you think the current state of play is for telemedicine, and how big of a role could this play, particularly in phases 1 and 2, and even beyond? And are there legal fixes you think need to be done in various states across the country in order to make it more plausible to implement on a wider scale?
Well, I think what we've learned, we've known for 20 years that telemedicine is effective. It's just that Medicare has been very slow to reimburse it. And obviously that was the catalyst. If one thing COVID did, it was a catalyst to really change and accelerate how Medicare has deregulated this industry. I mean, they literally said you don't need a HIPAA-compliant platform. That is our protective law against privacy. They said you could use a regular phone now. And so once we've done this, the genie's out of the bottle, and we've been using it in my practice. You know, I'm over doctors in 19 states, 2,000 doctors. We've already been using it, and now it's going to be hard to go backwards. So I think that it's been instrumental. However, I want to say one thing. If you're having a heart attack, you can't do that and treat that via telemedicine. And unfortunately, the problem that we had was we said lockdown, and patients heard that, and then they're staying home. You know, we've noticed heart attacks, serious heart attacks, are down 40, 50% in some of the emergency rooms, and we know they're still having them. So my one message out to everyone is, please, if you're having a stroke, if you're having a heart attack, can't treat that with telemedicine. We have ways to treat that very quickly, and time is of the essence. So I want to get that message out.
Yeah, I think it's so important to stress that point, Dr. Deruelle, because we've seen reports of people staying at home and having heart attacks and other heart issues that flare up, and yet they don't go to the ER to seek medical attention.
Absolutely. I talked to a cardiologist the other day, and she said that a patient had chest pain, thought it was COVID, and didn't come in, was afraid to come in. 4 days later, now his heart function will never be the same, and he had a chance to really save some of that precious heart. I also talked to one of my colleagues, a doctor, the other day, and a patient came in, had stroke symptoms, but it was 4 days later. If they had come in that same day, we have treatments and clot busters that we can use if you come in. And then finally, on Twitter, I saw a case of a cardiologist that had a ruptured ventricle. So that's something we never see, that septum rupture typically in heart attacks unless it's really late. And that's something that could have been prevented. So please, to everyone out there, you're not safer at home if you have something that needs to be treated. And by the way, half the ERs are empty anyway. So, you're going to be okay.
Again, we're talking with Dr. Dennis Deruelle, who's a physician and practicing hospitalist, also author of the book Your Healthcare Playbook, Winning the Game of Modern Medicine. Dr. Deruelle, when we talk about reopening America, obviously there are a lot of different things that the Trump administration wants states and people across the country to keep in mind: maintaining social distancing, slowly moving more and more into larger crowds and what have you. What do you think are the criteria that a state should be looking at? And of course, the administration's put some of this forward, and perhaps you can point to them in your answer, but that states should be keeping in mind when they feel comfortable and ready in their own territories to start opening things up from a medical standpoint, a healthcare standpoint.
Yeah, that's a great question. There's something called in epidemiology an R naught, which is really how many people, if I have coronavirus, can I infect or would I infect? And we've seen the R naught for this virus, it's very infectious, to be about 3, 3.5, or 4. That means if I have it, I'm going to give it to 3 people. Those 3 people give it to 3, and that's the exponential growth. So a lot of people are saying we need an R naught of 1, less than 1. And I just read that New York is now approaching that R naught of 1. And I know that in Tennessee, I live in Nashville, we have some of our areas of the state that are less than 1 for that, and some that are still up in the 2.5. And I'm surprised that the criteria didn't involve that statistic.
That's an interesting observation, Dr. Deruelle. So in terms of the social distancing aspect of this, I mean, obviously talking a lot here about phase 1, but when we get to phase 2 and phase 3, it will take time for us to get to a point where people will even feel comfortable going out into the public, but also for governments to say, sure, you can go ahead and crowds of 50, 150, 200, fill up a concert hall. How long do you think social distancing may last in some of these really strict guidelines?
Well, it's really funny. I just tweeted something that, this plan won't really drive what people do. The people will drive the plan, and they'll kind of self-correct. I mean, almost like a market. If people are afraid and they don't have the confidence, it doesn't matter if you open a bar or you reopen a stadium. And so, to me, the confidence has to be there, and in a way, it's gonna drive what we do.
So, Dr. Deruelle, when we look at confidence in this question, I think you're so right that people will make the decision themselves if they want to go out into public, whether governments opened it up or not. And that's why I think some of these restrictions can more easily, more quickly roll back, because people will take it upon themselves to make a decision. Do I feel comfortable going into the crowd? Do I want to go to this restaurant again? And so I don't think government will have to be too stringent for too long, because people are going to be smart for their own health concerns, I think.
Oh, absolutely. We've seen that patients have this propensity now to stay at home, even with really dire circumstances. So you've got to put that in perspective. And so, I think we'll self-regulate a lot of that. But you've got a couple of things that will also drive confidence. Number one, we're treating right now across my practices, we're treating about maybe 80 patients a day right now. And I'm tracking all the treatments that we're doing. I'm tracking all the outcomes. And as soon as we have something that is proven effective, that's going to be a big game changer. Number two, when we have a vaccine, so the things that'll drive confidence are when the cases are going down, when hospitalizations are going down, and when we have a better treatment or a proven treatment, and when we have a vaccine. So I think, when you talk about what confidence is, those are the things that I think the Americans will judge confidence on.
Let's talk about two things that people have been discussing quite a bit. One is hydroxychloroquine, and of course this potential treatment. Many doctors have been making the decision to prescribe it. Some politicians have said, no, we don't want you to, trying to block physicians from making that decision and in essence getting in the way of the doctor-patient relationship. We spent a lot of time talking about the legal ideas associated with Food and Drug Administration and governors and so forth relative to drugs like hydroxychloroquine, but also you mentioned earlier about antibody testing. So can you talk to us about both of those and the potential role you see as maybe helping to move along this process of reopening America, Dr. Deruelle?
Absolutely. Well, as far as I'm concerned, the best drug out there is remdesivir. There was just another study. It wasn't a study. It was a case series out of University of Chicago, 125 patients. Only 2 patients died, and these were pretty severe patients. So I like the drug remdesivir. There was also a 53-patient series that was in New England Journal last Friday that also showed very good benefits. However, it's hard to get. It's still only expanded access. So if I had to pick a drug today, that's the one I would want. However, you asked about hydroxychloroquine or Plaquenil, and the data on that is not that great. In fact, the most recent and the only randomized trial that came out of China showed that it wasn't beneficial in reducing the viral load. People got better symptomatically a little earlier. And then if you look at all the other studies for hydroxychloroquine, there's a good one in China, there's a good one in France, and a bad one. So when I look at all that data, I think that all we can do is wait for the data out of New York. Those are going to have many more patients, and we're going to see. My gut feeling is hydroxychloroquine is not going to be as effective as we think. However, almost every patient that we're treating in the hospital is on it. Because as doctors say, why would you not treat someone with it with a very low risk profile in the worst pandemic if we find out that it does work? So that's just my take.
How about antibody testing? Expand on that a little bit.
Oh, well, antibody testing is going to be huge. When we get an infection, we have 2 antibodies, IgM and IgG. IgM means we have the infection now. IgG comes later. It means we had it. And so when someone is positive for IgG, and their IgM is negative, that means they've already had it, and we didn't even know it. As I mentioned, many people we're going to find, I think, have had this. Different populations up to 20-30%, other populations about 4%. And so now the antibody doesn't mean you're immune, but the good news is that this virus has not mutated very much. So when you look at the virus from China and from Europe, the one protein, the spike that lets it get in cells, seems to be pretty constant right now. And that means that it's a better chance that if you have an antibody, it's going to be able to fight it. If the virus was mutating a lot, which it's not, then an antibody might not protect you.
Dr. Dennis Deruelle, our guest here on Jimmy at the Crossroads. Just a couple minutes left, and I'm curious. I want to play cut 3. This is Dr. Birx at the White House yesterday at the Coronavirus Task Force press conference talking about phase 2, which would be the next step in the process to reopen America. And we won't get into phase 3 per se, but I want to play phase 2 and see what you make of that and how quickly you think we might be able to get to that point, Dr. Deruelle.
Again, we're asking for the public to continue to maximize physical distance. However, we increased social settings to be able to now have 50 individuals, and non-essential travel can resume. Next slide. This is for the employers. We still would like to encourage telework, and the common areas should remain closed or be physically distanced. All non-essential travel for employees can resume. And then again, special accommodations for vulnerable. Next slide. This should be a relief to many of households that have small children. Schools, daycares, and camps can reopen in phase 2. Visits to senior living facilities, however, should remain in hospitals prohibited. Large venues can operate, but solely under moderate physical distancing, and elective surgeries can resume on an outpatient and inpatient basis.
I would say, Dr. Dennis Deruelle, that phase 2 is more the point where America starts to feel a little bit more like we're getting back to a pseudo sort of normal. There are some things in there that allow for more crowds, more gatherings, venues to open up, things along those lines. When do you think we might be able to get to that point, and what really needs to happen to get to phase 2?
Well, again, we're going to need confidence from the public. I think it's interesting when they talk about high-risk individuals. Let's realize that if you're obese, if you have hypertension, if you have cardiovascular disease or diabetes, do you know how many patients in America that are under 65 that have those? So, I think it's kind of interesting. That's almost 40% of the population or more. and they're supposed to still be, isolating at that time. So I think what's going to be interesting to me is how many people disregard that because they feel safe. But to answer your question, I think that that by August we should be in this phase, if not a little bit sooner than that.
And Dr. Dennis Deruelle, anything else you think the American people really need to know about the three-phase process and how quickly we might get back to normal, as we say? Anything we should be keeping in mind?
Yeah, well, my message to my mom, and I advised her on February 25th about to stay inside. She's a high-risk population, same with my dad. And so I think the biggest message is really, if you're in a high-risk population, you really got to watch these things. And also be careful. Just because you're high risk and you stay inside, if you have a family member that goes out and comes back, then you have to be very careful. And really, face masks in public, there was a great study in Nature that looked at how it's protective. And so it's protecting the projection of aerosols and droplets. So I think good hand washing, face masks, and high-risk populations really need to be most conservative in these measures.
Dr. Dennis Deruelle, MD, FHM, author of Your Healthcare Playbook, Winning the Game of Modern Medicine. So great to talk with you. Very insightful. Let's definitely have you back here on Jimmy at the Crossroads.
Anytime. Thanks a lot, Jimmy. Be safe.
You too. Have a great weekend as well.
Thanks.
Once again, Dr. Dennis Deruelle joining us here on Jimmy at the Crossroads. Such a pleasure.